Okay, so good evening. Thank you so much for joining us tonight. My name is Lkelly. I am the Adult Programming and Outreach Manager for the Long Branch Free Public Library. And I'm happy to welcome with us tonight for this workshop, Ashley Purper. She is the Community Cancer Outreach Specialist of the Rutgers Cancer Institute of New Jersey. And she's going to present our introduction to health disparities in the LGBTQ plus community. So I just wanted to go over that we will be saving questions for the end, but to please feel free to put them in the chat if you don't want to forget them, and then we'll go back and check. You are welcome to turn your video on if you would like, whatever you're most comfortable with tonight. We are both recording this program for a posting on our YouTube channel, and we are live streaming it to Facebook Live. So hi, Bonnie, welcome. We have more. So the program will take about 30 minutes, and then we'll have time for Q&A at the end. And just want to say thank you again. And Ashley, I don't want to take up any more of your time. So unless there are any quick questions at the start, I did put my contact info in the chat. If you'd like to reach out to me or have questions about anything else the library is doing, you can reach me at my email or just call the library and they'll find me, I'm sure. But otherwise, I'm going to turn it over to you, Ashley, now, and welcome and thank you again for presenting to us this evening.
Yes, absolutely. Thank you, Lisa, for having me. I will get started. Just bear with me while I get everything up and running here. I know the screen might look a little red for a second. It's just the Rutgers colors here. All right. Are you able to see the PowerPoint? Yes, okay.
Yes, looks good.
Okay, great. So hello, everyone. As Lisa said, my name is Ashley Purper. I go by she, her pronouns, and I'm here to present the introduction to health disparities in the LGBTQ plus community. I am a community cancer control specialist with Rutgers Cancer Institute of New Jersey. So before we get started, I just want to remind everyone this will be a safe space. It's a judgment-free zone, really intended for learning and growth. Please feel free to speak up with questions at any time, type them into the chat. If you want your question to be anonymous, send it as a private chat to either myself or Lisa. Or if, after the presentation, you're like, oh, I should have asked that. My email is here up on the screen. Feel free to email me at any time. It's ashley.purper@rutgers.edu. I'll also provide it again at the end. All right, so let's start with some introductions. As I mentioned before, my name is Ashley. I use she, her pronouns. If you feel comfortable enough to come off chat and introduce yourself, go for it. If not, type it in the chat. If even that feels a little uncomfy, just think of how you would introduce yourself to someone. I know sometimes using your pronouns after your introduction can seem a little awkward. So just the more you practice it and the more you say it, the more it kind of becomes the norm.
Yes, I'll start, Ashley,
Okay.
Because I realized I should have done that, and I'm still getting used to doing that. So my pronouns are she, her, and hers.
Thank you, Lisa.
You're welcome.
Well, I'm Bonnie Muir, and my pronouns are she, her.
Thank you, Bonnie. Thank you for joining us. Okay. Let's see. All right, so in today's workshop, we're going to cover the following objectives. We're going to quickly go over LGBTQ plus terminology and concepts, just so we're all coming from the same frame of mind. We're going to understand some of the health disparities and barriers to care that the population faces, and then we're going to explore some resources, both locally at the state level and at the national level. So before we really dive in, I just have a few what I like to call knowledge check-ins. The next few slides just have some multiple choice questions. Feel free to either answer in the chat or really just think about what the answer may be. I know we are on Facebook as well, or some of you might be watching this at a later time. So just this first question, what does the LGBTQ acronym stand for? And there's some options here. I'll give you a few moments to read them, figure out what the answer is. I'm not going to reveal the answer yet because we're going to check back in at the end of the presentation to see what we may have learned. I guess I'll just give it a few moments. And like I said, feel free to put it in the chat or really just think about it, and we'll come back to this at the end. So the next question, the next few are just true false questions. So this one is HPV, known as the human papillomavirus, is known to cause cancer. It's either A, true, or B, false. Can just give that a few seconds. All right. The next one is LGBTQ populations have the highest rates of tobacco, alcohol, and other drug use. Again, this is a true false question, A being true, B being false. Okay, and just one final one. This is another true false statement, just saying that all transgender people are gay. And this is again either A, true, or B, false. So just take a few moments to think about what your answer may be. Again, we will revisit these again at the end just to see if you may have learned something new or if it just reinforces that you already knew the answers. So first, we're just going to cover some terminology. In order to really understand the disparities and barriers, it's important for us to all have really that basic understanding of terms and concepts. So let's get started. So understanding the acronym, what does this alphabet soup stand for? Well, so the first letter of the acronym is the letter L, which stands for lesbian. And the term lesbian is used to describe a person who identifies as woman, being romantically or sexually attracted to other people who identify as women. The second letter of the acronym is the letter G. This stands for gay. The term gay is used to describe someone who is attracted to members of the same gender as themselves. Most of the time, this is used to describe men who are attracted to other men, but it can also be used to describe women who like other women. It is also sometimes used as, a catch-all term to describe the population. The third letter is the letter B, which stands for bisexual. The term bisexual describes someone who is either romantically or sexually attracted to both men and women. Keep in mind, some bisexual people find themselves more attracted to people who identify as female and more to people who identify as male. It's not always a 50-50 split. It can be fluctuating anywhere in between. The fourth letter in the acronym is the letter T. This stands for transgender. The term transgender describes someone who does not identify with the sex they were assigned at birth. So for example, a transgender woman is someone who was assigned male at birth and identifies as female. On the other hand, a transgender man is someone who was assigned female at birth and identifies as male. As just a side note, some of you may have heard the term non-binary. Some non-binary people might identify as transgender, some might not. And this really comes from the gender binary referring to the system where there are only two genders, male or female. So by definition, being non-binary is just someone who identifies outside of that binary. They may feel male and female, or neither, or anywhere in between. Keep in mind, when it comes to the trans community, people may decide to transition in different ways, including medically, where they take hormones, they get surgeries, etc. Socially, where they may ask people to use a certain name or a certain pronoun, or they just start dressing differently and presenting themselves in a different way. Or they might transition legally, where they change their name and gender markers on their legal identifications. Some people can transition all three ways, one way, two ways. It looks different on everyone, so we really want to avoid those assumptions. So before we move on, I just want to briefly go over the correct terminology when it comes to names. Some trans people might go by what is called their preferred or chosen name, which is different, often different from their legal name. And it's important not to refer to their legal name as their real name. This implies that trans people are playing a character and they're putting on a facade when that's not true. So you want to call them by their preferred or chosen name and only refer to their legal name as their legal name and in legal situations. So for example, if you have a friend named Nicholas, but on his legal documents it says Michelle, it's not appropriate to refer to the name Michelle as his real name or to call him Michelle. You would call him by his preferred or chosen name, which is Nicholas. And finally, the fifth letter in the acronym is Q, which stands for queer. The term queer is used to refer to anyone who is not straight and not cisgender. I know we talked a little bit about transgender, so the people who are not transgender are cisgender. And this is when your identity does match your sex assigned at birth. So for example, my name is Ashley. When I was born, the doctor went, "It's a girl," wrote female on my birth certificate, but I also identify as female, so I am a cisgender woman. I know the term queer might be viewed as controversial to some because it has been used as a slur throughout history, but many people are starting to reclaim the term and now kind of use it as the catch-all term for LGBTQ+. You may hear me using that interchangeably just because I will start to stutter over my words if I say LGBTQ too many times in a row. So I will go back and forth between using that and queer. You may not know all the terms, that's okay. LGBTQ people use a variety of terms to describe their identity and to talk about who they are. Just listen, pay attention to how people are talking about themselves, and then mirror their language. It's most important just to respect their self-identification. So we sometimes see the acronym written with a plus at the end, and the plus can represent really any sexual or gender identity that's not included in the L, G, B, or T. Some examples of these identities could be, intersex, which is someone whose anatomy doesn't fit neatly into that category of male, female. This could be someone who's pansexual, asexual, genderqueer, pangender, omnisexual. There's so many terms that people can use to present themselves. So again, the most important thing is to just respect self-identification. When someone tells you who they are and how they identify, just listen to them, repeat the language they're using. So now we've gone over the acronym briefly. We're going to focus a little bit, it's just one slide, just on the differences between sexual orientation, gender, and sex assigned at birth. So when it comes to understanding terminology, it's important to understand this difference. So, what is the difference? To start off, sex assigned at birth, we've talked a little bit about it. It's the label that your doctor gives you when you're born based on your anatomy. If your doctor writes M for male on your birth certificate, that means you were assigned male at birth. If they write F for female, that means you were assigned female at birth. On the other hand, gender refers to your innermost concept of self as male or female, a blend of both, neither. Your gender identity could be the same as your sex assigned at birth, which would make you cisgender, or maybe different, which would then be transgender, non-binary, anything you present yourself as. Keep in mind, gender identity is an adjective and not a noun. When it comes to transgender people, for example, you would say transgender people, not transgenders. You wouldn't use it in a past tense, transgendered. It's used as the adjective. And last but not least, sexual orientation refers to who you are attracted to. I mentioned some of these terms before, lesbian, gay, bisexual, pansexual. These all refer to a person's sexual orientation. Keep in mind, this can change throughout the course of one's life. Again, just respect self-identification. If you want an easy way to conceptualize it, gender identity is who you go to bed as, whereas sexual orientation is who you may go to bed with. And knowing someone's gender identity does not tell you anything about their sexual orientation and vice versa. So knowing someone identifies as a lesbian does not tell you anything about their gender identity, or knowing someone that that is male does not tell you anything about their sexual orientation. So now we're gonna dive into more of, the meat, the meat of this presentation, really get into health disparities. We're gonna review some common disparities faced by the community. But first, let's, what is a health disparity? What does that mean? Well, Healthy People 2020 defines a health disparity as a particular type of health difference that is closely linked with social, economic, or environmental disadvantage. Health disparities adversely affect groups of people who have systematically experienced greater obstacles to health based on their racial or ethnic group, religion, socioeconomic status, gender, age, mental health, cognitive, sensory, or physical ability, sexual orientation, gender identity, geographic location, or other characteristics historically linked to discrimination. A little simpler terms, the CDC defines a health disparity as a preventable difference in the burden of disease, injury, and violence. We're going to spend the next portion of the workshop discussing some of the common disparities faced by the queer community, as well as some reasons why these disparities may exist. On the screen, you will see some of the most common disparities faced by the LGBTQ population. I'll just read some of them aloud. LGBTQ youth are 2 to 3 times more likely to attempt suicide. LGBTQ youth are more likely to be homeless. Lesbians are less likely to get preventative services for cancer. Gay men are at a higher risk of HIV and other STDs, especially among communities of color. Lesbians and bisexual females are more likely to be overweight or obese. Transgender individuals have a high prevalence of HIV and STDs. LGBTQ populations have the highest rates of tobacco, alcohol, and other drug use. There are also high rates of violence against the community. These facts might seem a bit jarring to some people, so let's just briefly discuss some of the reasons why this may be happening. There's discrimination from family, peers, the medical community, and other services. There's often a lack of health insurance among members of the queer community. There's low levels of cultural competency from healthcare providers where they don't know how to appropriately treat members of the community. There's a lack of appropriate social services and programs tailored to the community. There's high rates of bullying in schools, combined with a lack of laws that prevent bullying. There's a lack of safe spaces and social spaces. There's targeted marketing of harmful products, i.e. the tobacco industry. We will get into this a little bit further in the presentation, that a lot of these companies target the LGBTQ community. And there's an inconsistent collection of data and surveys and health records. I'll talk about this a little bit later, that one of the biggest things is there's a lack of research into the community because doctors' offices and other medical facilities don't collect data about sexual orientation or gender identity as often as they should. So like I said, we're going to get a little bit deeper into each of these concepts. One of the biggest health disparities is smoking. So 20.5% of the community members partake in the use of tobacco products, while they represent only 8% of the population. LGBT adults are more likely to use cigarettes and twice as likely to use e-cigarettes when compared to non-LGBT adults. Transgender adults have higher odds of using cigarettes, e-cigarettes, hookah, and cigars. In addition to using tobacco products at higher rates, youth sexual minorities were more likely to use tobacco more heavily. So while they had friends that may have, smoked a few cigarettes a day, they're smoking a pack a day. Or, their friends smoke a pack a day, they're smoking 2 packs a day. So not only are more people smoking, they're smoking more. So research documenting the health disparities among LGBT individuals is growing, but there are still limited national data available regarding tobacco use among the LGBT community. The most current national data for LGBT youth and adult tobacco use rates are from 2016, emphasizing there's an urgent need to improve research in this community. The data that is available indicates that the LGBT community is disproportionately impacted by tobacco. And I don't want to bore you by reading a bunch more statistics because they are out there, but all trends do point to the fact that queer youth and adults are more likely to use tobacco products and use them more heavily when compared to their non-queer counterparts and peers. If you want to see a little bit more about this, truthinitiative.org really lays this out in a very comprehensive way. But why? Why are they smoking more? Why are they smoking more heavily? Well, for one, it's marketing. Tobacco companies used a multitude of methods to target the LGBT community, including advertising in gay press publications, depicting tobacco use as a normal part of the LGBT life, using corporate philanthropy as evidence of its support of the LGBT community, participating in giveaways, increasing advertising, and hosting community outreach efforts featuring specific cigarette brands. And we're seeing that all e-cigarette and vaping companies are following suit. You can see an example here on the screen. This snus, which is a smokeless tobacco, take pride in your flavor. They're using the rainbow down here in the corner. They're really, taking advantage of, I believe this even came out during Pride Month a couple years ago. Some studies also suggest that LGBTQ individuals also turn to tobacco more heavily, almost as a coping mechanism due to the added stress of being part of a minority population. And why is this important? Well, smoking can lead to immediate and chronic health conditions, including lung cancer. If you currently smoke, use vapes or other products, I'll provide some resources at the end of this presentation that can help you on your road to quitting. Next, let's look at HIV and the LGBTQ community. According to the CDC, in 2018, gay and bisexual men accounted for 69% of all new HIV diagnoses. 1 in 6 gay and bisexual men will be diagnosed with HIV in their lifetime. For Latino and Black men who have sex with men, the rates are 1 in 4 and 1 in 2, respectively. One international analysis found that transgender women in certain communities have 49 times the odds of living with HIV than the general population. So, what is HIV? HIV, also known as the human immunodeficiency virus, is a virus that attacks cells that help the body fight infection, making a person more vulnerable to other infections and diseases. It is spread by contact with certain bodily fluids of a person with HIV, most commonly during unprotected sex or through sharing of IV drug equipment. If left untreated, HIV can lead to the disease AIDS, the acquired immunodeficiency syndrome. HIV can affect anyone, regardless of sexual orientation, race, ethnicity, gender, age, or location. However, certain groups of people in the United States are more likely to get HIV than others because of particular factors, including the communities in which they live, what subpopulations they belong to, and their risk behaviors. Risk behaviors can include different sexual behaviors and IV drug use. And as we spoke about previously, LGBTQ individuals are more likely to partake in IV drug use, thus putting them at greater risk of HIV infection. LGBTQ individuals are also less likely to receive preventative care, thus making it less likely for them to receive HIV prevention medications or to even have the knowledge that this is still a very real thing. Another major disparity we see in the queer community is the high burden of HPV infections. An estimated 61% of HIV negative and 93% of HIV positive gay and bisexual men have anal HPV infections, compared to 50% or less of heterosexual men. Only about 25% of gay and bisexual men are knowledgeable about the relationship between HPV infection and anal cancer. Queer women are less likely to visit and utilize preventative health services, making them less informed about HPV. If you have a prior HPV infection, you are 32 times more likely to develop oral malignancies than those who have had not. HPV is the human papillomavirus, is the most commonly transmitted STI, and is a viral infection. While some HPV infections clear up on their own, some strains lead to the growth of warts, and if left untreated, can lead to cancer. Genital HPV is transmitted by skin-to-skin contact. Its risk is present in all LGBT people who engage in sex. Transmission occurs more easily in the presence of irritated skin, as often occurs with penetrative sex. For persons with poor immune system function, however, HPV infection may quickly progress to severe cancer. For this reason, HIV positive gay or bisexual men with higher levels of both HPV infection and HPV related disease than heterosexual men. Women who have sex with women can contract the virus from an infected partner in the same way heterosexual women can, including through genital-to-genital contact, touching the genitals of a partner and then one's own, or sharing toys without cleaning them properly first. Some lesbians have also experienced heterosexual intercourse, increasing their risk for HPV. However, lesbians are less likely to regularly visit a reproductive health specialist and are therefore less exposed to information about HPV or to make use of the preventative steps developed for women. As I mentioned, HPV can lead to several different types of cancer, and the LGBTQ plus community is disproportionately affected by cervical, anal, and oral cancers. As I mentioned, many queer women delay or forego proper preventative care and screening because they believe they are not at risk for developing STIs or HPV. And as I noted before, women who have sex with women can contract the virus in the same way that any woman can, and they are less likely to be screened regularly, which puts them at a higher risk. Men who have sex with men are also at increased risk for anal cancer compared to the general population. Since the HPV virus is easily transmitted through skin mucosal contact, oral sex is a potential vehicle for transmission from the genital areas of the mouth, and HPV seems to play an independent role in the development of almost 30% of oral cancers. LGBTQ plus individuals are at a higher risk for HPV infection, thus making them at a higher risk for developing cancer. So what can you do? Well, there's an approved vaccine that will help protect you against the most common strains of HPV. And it is the only vaccine out there that is known to prevent cancer, because if it's preventing those HPV infections, it's helping to prevent those cancers that are related to those strains of HPV. Now we're just going to talk a little bit about cancer in general in the LGBTQ plus population. Lesbian and bisexual women are at a greater risk for developing breast cancer. Gay men with prostate cancer have some additional social and sexual challenges that are rarely addressed adequately by their oncologists and social workers. Transgender people have extremely high rates of smoking, drinking, and HIV, which all increases their risks for developing an array of cancers, including lung, anal, and liver cancer. While there's no biological reason for LGBTQ plus persons to develop cancer at higher rates, there are social barriers and other social factors that contribute to the queer population being diagnosed at higher rates or at later stages of the disease. And this is common in all chronic diseases, not just cancer. If you're not going to the doctor, you're not catching diseases early enough that they're more easily treated. And disparities exist not only in rates and stages of diagnosis, but exist within the treatment, recovery, and survivorship. So you may be thinking, why do lesbian and bisexual women have this greater risk? Well, it's been found that there's a higher rate of obesity, higher rates of smoking. Queer women are less likely to have biological children before the age of 30. And it has been shown through several studies that having biological children before the age of 30 will help prevent certain breast cancers. There's also lower rates of breastfeeding. And as I mentioned, lower rates of preventative care. They're not going to the doctors, they're not getting their mammograms, they're not getting the proper screenings at the proper times. We spoke previously about how men who have sex with men have higher rates of HPV, leading to higher rates of certain cancers. Well, prostate cancer is one of the most common cancers in men in general. However, men who have sex with men have greater challenges during and post-treatment than the general male population. Again, there's no increased risk for prostate cancer due to sexual orientation, but men who have sex with men are more negatively impacted by the side effects, including issues with sexual intimacy post-diagnosis and post-treatment. There are very few resources to help these men overcome the challenges post-diagnosis and treatment when compared to the general population. The transgender population is also at greater risk for not only developing cancer, but facing many challenges in receiving proper treatment from diagnosis onward. along with having those high rates of smoking, drinking, drug use, and HIV, which leads to a greater risk of cancer and other chronic disease. Transgender people also have extremely low rates of proper screening and overall preventative care, leading to diagnosis at later stages. This can be due to fear, discrimination, lack of social services, and numerous other factors. It has also been noted that transgender people feel disconnected from certain parts of their body. For example, a transgender man, someone who was assigned female at birth, may not seek gynecological services. They might not be going, if they still have a uterus, they might not be going to get that checked just because they feel like it's not part of them, not part of their body. Similarly, a transgender woman, someone who was assigned male at birth, might not be seeking, prostate cancer screenings, or their doctor might not know enough to suggest they should be getting prostate screenings. Health disparities exist both within sexual minority populations as well as between these populations and their heterosexual counterparts. And while this group shares a disproportionate cancer burden compared to the rest of the population, studies should go further in testing and determining the uniqueness of this burden for the individual members of the community. As I noted, LGBTQ+ people face many factors that contribute to these health disparities. We refer to these factors as barriers to care. And these barriers to care come from the social determinants of health. So what does social determinants of health mean? I know I'm throwing a lot of technical terms here. These determinants of health are economic, environmental, and social conditions that determine health. Disparities in health and healthcare reflect ongoing injustices in our society or historical discriminatory practices, such as those related to race, ethnicity, socioeconomic status, and sexual or gender identity. Health disparities of the LGBTQ populations are largely effects of social disadvantage and discrimination, including but not limited to legal discrimination in accessing healthcare, housing, and benefits, lack of laws protecting LGBTQ people, unavailability of social programs, and a shortage of culturally competent health workers. There are many factors that contribute to these health disparities as highlighted in this graphic. Queer populations have higher rates of homelessness and lower rates of health insurance. As I've mentioned several times, they have higher rates of smoking, IV drug use, and alcohol use. A lot of these behaviors are due to the added stress that go along with being considered a minority population, such as discrimination, prejudice, and stigma. This can come from peers, family members, and just the community at large. One major contributing factor is potential discrimination in the healthcare setting. It has been noted that many LGBT individuals delay or forego going to the doctor due to fear of discrimination or lack of competent providers. Delaying or not seeking preventative care can lead to undiagnosed disease or receiving a diagnosis at later stages. According to the National LGBT Cancer Network, 60% of oncologists feel they do not know enough to treat LGBT patients, and 80% feel they do not know enough to treat transgender patients. All of these factors combined with an overall lack of research and data leads to a high disease burden, including HIV, HPV, and cancer within the LGBTQ population. So I just want to share a quick video that highlights some of the issues that the LGBTQ population faces in healthcare, both as patients and as caregivers. Hopefully I can get this to play. I'm not sure which screen I need to play it from. So just bear with me and let me know if and when it starts playing.
Good, Ashley.
Are you able to hear it?
To treat me, you have to know who I am. I identify as a Latina lesbian mother.
To treat me, you have to know who I am. I identify as a transgender man.
To treat me, you have to know who I am. I identify as a gay man.
When I was about 15 years old, I remember going into the doctor's office, and I remember telling her when she asked about my sexual activity if if I use condoms or anything like that, and I said, no, I'm gay. And I just remember her face changed very much, and her warm tone of voice turned very harsh, and it seemed as though she was rushing me out as quickly as possible.
I do think the LGBT community has special needs. I think the LGBT community has a specific special need, which is to be treated the way non-LGBT people have been treated forever, which is to be asked about their sexuality, to be asked about their quality of life, what their home situation is, what their work situation is, what their friend situation is, without the person asking the questions being afraid of what the answers might be.
My partner and I and our children were on a family vacation, and my older daughter became sick. And we get to the hospital, and they asked who was my daughter's parents, and I said, well, she has two moms. And they were like, well, she can't have two moms, only one of you can go in. My daughter was traumatized by that. We were traumatized by that.
My partner was hospitalized recently. When he was being moved from intensive care to a hospital bed, the nurse in charge would not let me accompany him. I asked if I would have been allowed to accompany him if I were part of his family, and she looked the other way.
What needs to happen when a patient is admitted to a hospital is that the care providers think about the fact that the patient might have different sexual orientation or different gender identity than the care provider.
The people who were dealing with me throughout my pregnancy, primarily my midwife and the nurses associated with them, were not responsive to my identity and didn't actually respect it.
When I was diagnosed with breast cancer, I found that my breast surgeon was unable to call me, even to give me my biopsy results. He did tell me very frankly and overtly that he had problems with my transgender status, and upon meeting me and learning of my transgender status, he decided that his first impulse was to refer me to psychiatry.
It's not about sensitivity, it's about respect, it's about humanitarian response to a human being in general.
To treat me, you have to know who I am. I identify as a lesbian.
To treat me, you have to know who I am. I identify as a genderqueer, biracial, Latino parent.
All right. So I just felt that video can highlight things a little bit better than I can. I know it was heavy, but what does give me a little bit of hope is that you saw there were doctors on there were nurse practitioners that are advocating, and we're really hoping to start seeing some change. I understand that was a lot of information, and a lot of it could have felt very discouraging, very heavy, but there are resources all across New Jersey. We're going to go over some of these resources now. First, let's just talk about tobacco cessation. As we've mentioned, LGBTQ+ individuals use tobacco at higher rates and more heavily due to targeted advertising, societal pressures, and stress. I want to note that all of these services you see on the screen are completely free of charge to anyone who can access them. So there's Mom's Quick Connection for families and Quit for kids. This is free individual telephone or face-to-face counseling to families with children under the age of 7. They also have a texting support program. The link is here. I will be able to send a bunch of these links to Lisa, so she will have them if you would like to share them or access them, because I don't think we can click on them on the PowerPoint here. So the National Cancer Institute, smokefree.gov. This site offers free services and resources and information. They have an app that can help you track your progress, offer helpful advice. This specific link on the screen leads you directly to their programs for LGBTQ+ specific individuals. We have the NJ Quit line, free telephone-based counseling for anyone 18+. You can call the line to register, or you can register online. They give you emails, tips throughout the process. You can also request free patches. Also, these NJ Quit centers, staffed with tobacco treatment specialists. Their free assessments, individualized treatment, group counseling, be on the phone, video, in person. They have free nicotine replacement therapy for clients and all sorts of other services. There's actually another service I actually learned about very recently. I didn't even get a chance to put it on the slide. If you text vape free NJ to 88709, this is for youth ages 13 to 24, and they will send you free resources and support you throughout the entire process. Again, I can put that in the chat later, but it's, if you text vape free NJ as one word to 88709, again, all completely free. Some primary care resources. I've mentioned it a few times that LGBTQ plus people are less likely to seek preventative care. And this is partly because of fear of discrimination or the fear of non-culturally competent providers. So here are a few of the services that have LGBTQ specific services with providers that are very well trained. I tried to focus on those services in and around Monmouth County, but there are several others out there. So there's the LGBTQ Center for Health and Wellness. This is in Asbury Park, and they offer primary care and a bunch of other services. There's the Proud Gender Center of New Jersey. This is in New Brunswick. They do gender affirming surgery, hormone therapy, also primary care. There's also the Sipperstein Proud Center in Somerville. There are other LGBTQ specific primary care offices around the state. If you're interested in learning more, feel free to email me, or you can visit outinNJ.net, and that's a directory of all the primary care resources in New Jersey that are specific to the LGBTQ population. Again, I will gladly share that link at the end. And these are just some other general resources around the state. PFLAG of Jersey Shore, the Pride Center of New Jersey, Q-Spot, Garden State Equality. They're all located in Monmouth County, mostly in Asbury Park. They offer various support services, advocacy, and support groups. Out in Jersey is a large community portal. I mentioned it before. It's a directory of various resources, whether you're looking for a support group or smoking cessation, primary care, gender affirming care, anything. They have services listed on there for New Jersey. The National LGBT Cancer Network is a great hub of information for those affected by cancer in any way. They aim to improve the lives of LGBT cancer survivors by way of education, training, and advocacy. They also have resources and information for caregivers. Again, I can share all these links. I'll put them in the chat. I'll share them with Lisa. Or like I said, you can email me directly, and I will gladly share anything. All right, so that really ended the session. We're going to go back to these knowledge check-ins just to reveal the answers. So again, what does the LGBTQ acronym stand for? The correct answer was letter D. It stands for lesbian, gay, bisexual, transgender, and queer. HPV, the human papillomavirus, is known to cause cancer. The correct answer was A, true. This one is dual screen. I looked at the wrong slide for a second. This next one, LGBTQ populations have the highest rates of tobacco, alcohol, and other drug use. This one was also A, true. And this final one, all transgender people are gay. This is false. As I mentioned, knowing someone's gender identity doesn't tell you anything about their orientation and vice versa. So that brings us to the end of the workshop. Thank you all for either joining in live, watching on Facebook, or watching this in the future. If you could take a moment just to complete this evaluation survey, just to let us know how we can improve or if there's anything you'd like to hear in the future. Yeah, now time for some Q&A if anyone has any questions. I can't really see the chat or anything, but I know Lisa said you were monitoring a little bit if anything came through.
I did not see any questions in the chat. That was great presentation. Thank you, Ashley.
Of
There was some
course.
info in there that I learned that I was unfamiliar with, and those are very sad statistics as well. And I was glad to see there was a clinic, medical clinic specifically for that population fairly close to us in Asbury Park. You know, and I just hope some of those statistics will change in the future. Because
Absolutely.
everyone should feel comfortable going to the doctor. And early diagnosis is so important. So
Yes,
it's good to be aware.
I'm just going to stop sharing for a moment just so I can put some things in the chat, put my email in the chat. Like I said, if anyone wants direction to any of those resources, please feel free to email me at any time.
Well, can you speak a little bit about the cancer screenings that might be available through your outreach, Ashley? Are those available to individuals, or is it something you would have to participate in a certain program or an event or a date and time kind of thing?
Right. So my department, we don't perform the screenings yet, but we are in the process of getting a mobile screening van. We have the van, just not, we're in the process of all the logistics at the state level, you know, getting it licensed and everything. So we will hopefully be present at community fairs, community resources. We're hoping to bring that to resource centers, and that will be able to, will be staffed by an APN. We also have a great patient navigation team. Lisa, I don't have their number on me, but I can send it to you that if you need help connecting to any cancer screening resources, they'll be able to help you make the appointment, find transportation, find, you know, really anything that can help you get to these screening resources. And Asbury Park is such a great hub. There really is a lot in Asbury Park for the population, a lot of different social services. So I'm glad Long Branch is, you know, relatively close to Asbury Park.
We also have a full-time social worker on staff, which we're very proud of. So he can refer people to, you know, places where they can receive most of the services they might need. But keep us in mind for that mobile screening service when you're up and running. We would be very interested in having you here at some of our large community events. So
yes,
thank you.
Absolutely. We're hopeful. We're hopeful it will be within the next few months. We have the APN, we have the van, so it's coming. We just don't have a specific date yet.
Oh, thank you, and thank you to Bonnie and Thalia and everyone who joined us tonight. I hope you learned something new or something useful, and I'll be happy to send that information to you. You can reach out to me through the library, and I will follow up. So I hope everyone has a really nice rest of their evening and a good week and a good summer and stays in good health. So thank you again, and so long.
Good night.
Thank you.
Good night.